I'm Anthony Mingy from Fitch & Associates, specialist in emergency services consulting, management, and long-term strategy development, and developers and host of the annual Pinnacle EMS Leadership Conference. I want to welcome and thank you for joining today's webcast, Saving Time and Money, Dispatch and Deployment Strategies for Non-Emergency Transports. This is part of the Pinnacle webinar series brought to you by Fitch & Associates and Ninth Brain. Scheduling and deployment are critical but often overlooked aspects of non-emergency medical transport that impact crews, patients, and your bottom line. Agencies that offer both 911 response and non-emergency services often focus so much on the emergency response systems that they miss opportunities to increase efficiencies in their non-emergent operations. Corinne Walser, Operations Manager for Medic in Charlotte, North Carolina, will show how the agency uses data to assist its scheduled transport operations and what steps Medic is taking to make them more efficient. Walser will discuss how Medic was able to stabilize unit-hour utilization for non-emergent transport units, reduce drive times and overall time on task with a data-driven deployment strategy, and improve employee morale by showing that the organization was working smarter, not harder, to become a more efficient operation. This presentation will be recorded, and we will include an access link in the post-webinar follow-up email. Ninth Brain users can also access the presentation on the webinars tab of your NDS dashboard. If you have questions during the presentation, please type them into your question area of your GoToWebinar panel. After Corinne's presentation, we will ask her questions. If you have technical support questions, you can type those into the question area as well. We will type a response back to you or share with the entire group if pertinent. Before we begin, I would like to thank the sponsor of this webcast, Bradshaw Consulting Services. Based in Aiken, South Carolina, Bradshaw Consulting Services, or BCS, was founded with the belief that geographic information systems, known as GIS, can help make a positive impact in people's lives. BCS's mission is to provide innovative GIS solutions to commercial and government clients throughout the world by offering unique solutions for the mobile, addressing, and public safety sectors. At Pinnacle 2017, BCS is introducing NetCall, their newest application for EMS. NetCall is the first application that uses advanced analytics, ADL, and GIS alongside your CAD to efficiently manage the dispatch of non-emergency vehicles. I also want to thank our Pinnacle education partner, Ninth Brain, for providing the platform and hosting this webinar. Ninth Brain provides a software as a service, web-based solution to help bring simplicity to their clients' working lives. Their suite of tools assist you with managing your data, providing continuing education, tracking regulatory requirements, as well as maintaining your day-to-day operational needs for crew scheduling, from building and checklists. They strive to be a one-stop shop for your online software needs. It is now my pleasure to introduce our speaker. Corinne began her career in communications while working on her bachelor's degree in criminal justice as a student dispatcher with the University Police Department in Kentucky. In 1996, Corinne moved to Charlotte, where she accepted a position with Mecklenburg EMS Agency in Charlotte, North Carolina, as a telecommunicator. From the position of telecommunicator, Corinne has remained in the communications division at Medic, working her way up the chain to the position of operations manager. She was promoted to the position of operations manager in December 2015, with her predecessor retired. I will now turn the presentation over to Corinne.
Good afternoon. Thank you all for joining us. So like the introduction said, I am operations manager for Mecklenburg EMS Agency, also known as Medic. Medic has been serving Mecklenburg County and the city of Charlotte since 1978. We operate the busiest 911 emergency medical service agency in the state of North Carolina. We are independently operated under the county, under Mecklenburg County government, and Medic's responsibilities span 544 square miles. The current incarnation began a little over 20 years ago when a unique partnership was formed between Mecklenburg County, Carolina's healthcare system, and Novant Health, which are our two hospital partners, our two hospital partner systems. Our strong relationship with those partners has allowed our agency to become an integral part of healthcare in our community. In FY16, Medic experienced unprecedented growth. The demand for medic services grew by 7% this past fiscal year, resulting in 139,214 transport responses. Pardon me, I'm having a little technical difficulty myself. There we go. Sorry about that. So Medic's overall patient volume has grown by 42% since 2010. That's a figure that's more than twice the growth of Mecklenburg County's population. We believe that we will see additional growth from that 7% in this fiscal year as well. In front of you is Medic's purpose statement: to save a life, hold a hand, and be prepared to respond in our community when and where our patients need us. Every move that we make, every change that we make to any process at Medic, every decision that we look at to implement change is done with this statement in mind. Our goal is to first take care of patients in the community that we serve. It's not a goal that we set just so that others can see it, this purpose statement. It is one that we try to accomplish in every action that we take and every patient that we arrive on scene with. From financial services and billing to our operations support technicians that stock our units for deployment, every employee at Medic is aimed at this same mission statement all day, every day. This is an OVS map. OVS stands for Organizational View as a System. This is Medic specific. This map reflects all pieces of our agency and how they work together to meet this agency purpose. So if you look in the middle of the page, you'll see where operations, and where my department in particular spends most of their time. This is where our work is done for 911 as well as for NET. Our goal is to produce resources, and that can be ALS or BLS, distribute those resources, as well as receiving and responding to each request appropriately with an end result of that clinical care provision to our customers. We anticipate that we will see the biggest impact in this area of our OVS map and our collaboration effort with BCS for NET call implementation. In FY16, Medic transported 107,460 patients. Of those 107,000 patients, 18% were scheduled transports. They're seen here as non-emergency transports. We transported more scheduled transports last year, more NET patients, than we did life-threatening patients and potentially life-threatening patients combined. So this reflects it and just shows you how important the NET side of our business is, not only at Medic, but I know this is industry-wide. These are a couple of our dashboards. Our performance goals are to be at the patient's side for a NET call for a scheduled transport no later than 1 second from the time that we promised that patient we would be there. If a hospital calls and requests a 1400 pickup and Medic says, no, that hour is full, but we can be there at 1500 instead, if we arrive with a patient at 1500 and 1 second, we're considered late for that transport. Our response time compliance, that response time compliance is monitored by taking the number of calls scheduled that we are late for divided by the total number of NET responses to find that compliance. So we can do that by hour, we can do that by week, we can do that by month. If we are scheduled for 100 transports in a given day and we're late 20 times for the promised pickup time, our compliance score would obviously be 80%. Currently, our goal for NET compliance is 80% for each month. Some days are better than others, obviously. During the week makes a difference, and on the weekend does too. For June currently, as of this moment, we're at 82.87% compliance. So for May, on the 28th of the month, we were at 76.97% compliance. So you can see the difference there. Resources, call volume, all of those things make a difference in that response time piece. Call volume is just not that consistent 7 days a week. We have fewer NET transport or scheduled transports on the weekend. Most of those are out of the emergency department at our local hospital. Another measure that we use that you can see to the right there is UHU. We measure this on the 911 as well as on the NET side. Our unit utilization is defined as the calculation when dividing the number of transports by the number of unit hours that are produced in our system. So for example, a unit that works 10 hours and handles 5 assignments would have a UHU of 0.5. That 0.5 is our goal for the net units, whether ALS or BLS. So we want to work them smarter, not harder. And this discussion leads us to forecasting demand. So this is what Mecklenburg County looks like. You can see the demand there. The red is high demand. The purple is even higher. So the purple is where the majority of our responses are coming from. This demand currently is for P5s, P6, which is a priority type. Those are both scheduled net ALS and BLS resources, or call types. And then the 15 and 16, we actually have a campus transport group that we do through Carolinas Medical Center. So those are different priorities, and we look at those a little bit differently. Combined net demand is all 4 priorities put together. So we've used the demand monitor as our tool. The BCS's demand monitor is our tool for analyzing many years of data, and we use calculations and formulas that help us predict when and where incidents are most likely to occur. Historically, we've done those for our highest priority calls, our deltas and echo calls. Available unit hours are defined as the amount of time that an ambulance is available to respond during a shift. So obviously the impact is huge for both workload as well as for work efficiency as it relates to those available hours. Our controller in communications is then responsible for ensuring that units or resources are deployed appropriately and moved throughout the county to meet that demand. We want to make sure that we have optimal coverage at all hours. So even if we only have a handful of units left in the county, we want to make sure they are ready to respond where they're needed next. We anticipate that the use of the demand monitor will assist us in the same way for forecasting net demand. It is more complicated when you drill down in ALS versus BLS, and then when you drill down again into time on task for a scheduled call. Patients that are transported to an emergency department, obviously those transports last a little bit less time than an actual net call would, and we'll get into some of that in a moment. So let's talk about time on task for a bit. Time on task for medic for 911 transports is a goal of 70 minutes. So that's from the time that the call is assigned, the unit is assigned to that call, to respond to an incident, when they transport, and ends when the ambulance is available and ready to respond to another call or for posting. So we know that work that we did in 2013 to reduce this time on task returned huge dividends for us in available unit hours. Increasing available unit hours can certainly be accomplished by purchasing more unit hours and adding those hours to the schedule. So you would just have more units and they would be able to take care of that volume. Medic's option was to increase the efficiency of the units that we already had on the schedule. In other words, work smarter, not harder. We recognized immediately that net calls historically do take longer from assignment to available. We recognize that this can be due to several different factors, to include on-scene time. Some facilities take longer for pickup, paperwork's not ready, patient needs to be disconnected from equipment. All of those different pieces are important, and we realize that those are going to happen. So in addition, we realize that once we arrive at a final destination time, whether it's a skilled facility, another hospital, that it takes some facilities longer to accept a patient even though they know that we're coming. So some nursing homes will take a little bit longer once we arrive. The largest impact, however, we believe that we may see is the en route time, or the time from call assignment to arrive at a pickup location. We anticipate that net call will give us a tool to gauge how to schedule a net unit, whether ALS or BLS assignment, throughout the day. Would still be a dynamic process, obviously, because we do have to anticipate that we may not have enough net units, that the higher priority 911 calls may come into play, or that we may need to pull a unit from the 911 side into the net call deployment. So Medic covers 544 square miles. We have 10 in-county hospitals. We are the only available stretcher transport capable resource in Mecklenburg County, even though each hospital system does have ground transport capability. Those units primarily handle transports within each of their hospital systems. We primarily utilize our net crews, our non-emergency transport crews, ALS and BLS, for scheduled calls in the most effective and equitable manner possible. Currently, during the week, we have as many as 70 to 80% of our scheduled transports that are completed just by our net crews. So the 911 crews do not have as many net calls or as many scheduled transports that they run. They strictly for the most part, stay over on the 911 side. Our goal is to look at net call, and we believe that net call will enable us to ensure that we are working those crews smarter, not harder. We think we'll see an increase in the number of net or scheduled transports that are completed by those net crews. So we think that that 70 to 80% will increase to as much as 90 or 95% in the end. This means less time between tasks, which results in that higher and that more appropriate UHU. So this slide shows our steps towards implementation of NetCall. We're currently still in the remote testing on data with current net processes, as well as in the refinement stages of the product. We're moving very quickly towards the implementation of this NetCall piece. MEDIC has oversight of this collaborative effort with BCS with the following individuals. These are the decision makers and those who are completing testing to ensure validation, to make sure we're making the right decisions, that we're creating the right processes, and our knowledge and the validation that the product is working as it's expected. Our net controllers are telecommunicators who are responsible for day in and day out work in the communication center. They enter transport requests, they ensure that complete paperwork is submitted and available for submission to billing. They are the system status controllers. We have system status controllers on the 911 side. We also have them on the net side because we want to make sure that both the 911 and the net resources are being deployed appropriately. Net supervisors are the supervisors of field net employees who report to the next position higher of operations manager of net. The net manager and my position of operations manager and communications work very closely together to oversee both field operations net and communications net. If there's a break in our ability to function as a unit, then obviously none of the processes that we have worked to put into place will continue to function. So this is one of the charts that we use for our daily ops briefing. Each morning at 10 o'clock, operations and communications and operations leadership circle for about a 15-minute time frame. We review the previous day's activity. We look at the number of transports that we had, both 911 and net. We look at the response time compliance for 911 and net, unit utilization for both, the number of hours on the schedule for both 911 and net. So you can see on this particular chart, the blue bar at the bottom, the very bottom, the small one, represent BLS resource hours. The green bars above that are ALS resource hours. Just as a side note, we are working to remove the net ALS hours from this chart. Currently, they're both are included in that green bar, both ALS net and ALS 911. The purple line represents the number of transports each hour. You can see peaks that come up around 20 per hour at some point. The red dots are the number of priority 1, the Delta and Echo responses that we did not meet our 10-minute and 59-second response time goal. So we look at those individually. We also have a chart that we use to look at why those were exceptions. Why did we not make those calls? We track that information, why we didn't make those calls for net and for 911 calls. So we're able to look and say, hey, did we need more resources? Did the hospital not call soon enough? Did we, have an accident and have to reassign a different unit on the way to a call? Those are the sorts of things that we want to know, so we can know how to do that and how to fix that in the future. Our goal is that very soon that we'll have a separate chart that looks very similar in nature, where we can see this for 911 and for net. At the bottom, you can see the numbers that go along for each hour of the day. That is our unit utilization piece. We look at those. It makes a difference because you can see at 9 o'clock this particular day, we're at a 0.42. It's kind of red. We're looking, working a little bit harder. You can see the next hour was a 0.25. So it varies over time, and we recognize that, but we try to keep it, stable throughout the day. So in regards to fleet management, we do have ALS and BLS units. We have 911 and non-emergency units. This represents our ability to manage our fleet and use our resources appropriately to make sure we are covering both. NetCall will assist with this process and will be able to let us know when this occurs or when it needs to occur and how often. We know there are occasions where net demand will exceed our available net resources, and at that point a truck will need to be moved over from the 911 ALS side to the net side to handle those transports. Then once that net transport is complete, that resource can move right back over to the 911 side and continue their day. Currently, both net and 911 units function under one operations budget. We are working to change that because of what we know. We know that an ALS unit requires a paramedic, therefore is a little bit higher rate of pay than a BLS unit, which would be 2 basic EMTs. Therefore, the cost of that unit hour and the cost of that crew is a little bit more for ALS. We know that because we have sprinters that are primarily utilized by our BLS crews, that those units are more efficient on gas than our ALS units, and therefore cost per mile is reduced. We know that an ALS unit requires more equipment, more drugs than a BLS unit. So we want to know that what we're spending in each area is a smart move so that we know how to improve processes in order to be more cost effective in our net business. NetCall will help us in this area as recommendations of schedules are made for units. In other words, can a BLS unit handle a particular call, leaving the ALS unit available for the correct response? So for the Deltas and Echo calls, for the 911 calls, as well as for an ALS net call or an ALS scheduled call where a patient's on a cardiac monitor or a patient has more medications than a BLS unit can monitor. So this is one of the dashboards from Marvelous, from our net call, and this looks at each net incidents, during a particular day. You can see that the data will give us value in each column. The status field enables us to see where each unit, where each incident is in the process. So if they're depart scene, if they're at their pickup location, drop-off location, that sort of thing. This is another dashboard in NetCall, and this enables us to see how we are using resources within the net system and be able to see the plan that's being recommended for each unit. As we talked about earlier, as units move from the 911 side to the net side, these units will optimize here while handling a net unit or a net incident, and then they'll be moved back over when that incident is complete. The colors will enable us to see easily where a unit is in their assignment and see the estimation of time that they have to complete each task. The time estimate is based on a history for that particular location as a pickup location or as a drop-off location, because we know that those are different, and we anticipate that that is a distinct difference for most facilities. We can, drop a patient off at Levine Cancer Institute. Obviously, it's going to take them a little bit longer to get a patient settled. They have to get them moved over. They have to get their medication started, that sort of thing. And then once we pick them up, they're typically ready to go. But by the time we arrive, they're ready to be transported back to their destination. So these are our goals. This is what we think and what we anticipate net change looks like. We believe that we will increase and stabilize net response time performance. Our goal is 5% improvement for that measure. We actually anticipate it may be as high as 87 or 88% within that first 6-month period. As far as time on task, we believe that we'll see a decrease of the net incident time on task. We believe that we'll be working more efficiently, and once we see how long particular facilities take for pickup and for drop-off, we believe that ability will enable us to remove a manual process for unit assignment and instead have solid data behind that recommendation for those unit assignments. And we'll see noticeable improvement for that time on task as well. As for improvement of net staff morale, giving a crew the ability to work smarter, not harder, will improve both morale of our field crews and our communications employees. Within CMED or within communications, this will be a huge change in that we will have a tool that we'll be able to utilize that gives us a lot of information up front by making that recommendation. At the moment, that is just a feeling. We think that it takes longer at this particular location, so we make this decision based on that information. NetCall will enable us to make that objective instead of subjective. The ability for things to change dynamically instead of just decisions being made this way by one net controller and this way by another net controller will definitely give us additional measures of performance for those net controllers. That will help in performance evaluation measures and help in performance overall. It also will give them the confidence in their decisions and their decision-making ability for the system. And that's all I have. Are there any questions? So do you share goals with the whole staff, or is it primarily a tool for focus of leadership? We absolutely share with our entire staff. We have regular in-service meetings where leadership, where operations managers, where someone is focusing on getting information to the employees. For any process change that we do or any improvement project work that we do, we give regular updates at that monthly in-service piece, and that's for field employees as well as for communications employees. In addition, work on those improvement projects, we actually have employees who are part of those improvement projects as well, so that they help make those decisions. Probably the one that we're most proud of right now is our unit deployment. We actually have new Dodge trucks that we just moved to, and employees actually help make those decisions. We actually set up units in the back. We put the units up as we would expect the unit or the crew to be able to do work, and they actually help make those decisions. So that's kind of how we get that out there to everybody. We do performance measures on a regular basis. Those are tracked. Those are reported weekly out in our what we call our medic dispatch, which is our newsletter out to our employees. Sorry. It's also a part of their performance evaluation, and we do quarterly reviews. We don't give increases every quarter, pay increases, that would be super nice, but we actually do yearly increases, and we do quarterly report outs on how they're doing and how they're performing.
Okay, we have more questions here. The first question is, what is the speaker's name, please? And it is Corinne Walser. The next question is, how do you triage who gets NET and who gets 911 responses?
So we actually have our 911 system set up so that if you dial 911, it goes to a particular line. For net calls, we actually have 2 non-emergency lines that are set up in our center. We also have a multitude of other admin lines. But primarily those who call to schedule a transport, you can look that up on our website. You can get that number, then you can call in to get that information. For our hospitals, actually, it's a little bit easier. We actually have a standard net form. We fax that over. If they don't have it, typically they already have it. They can already complete that information. Currently, that's a manual process as well. That's something that we're looking at for the net call product to do next, and that is for the customer on their side to be able to enter that information into the computer, and for net call to either accept it if they have all the right information and everything is complete, or to deny it and send it back if everything's not there. So we do that. That's a manual process for us right now. A little antiquated considering we use a fax machine, but it's working currently.
Okay, a follow-up question to that, and how do you manage clinical risk in this manner?
So can you give me an example of what that might refer to? I'm not sure what I'm understanding. So are you talking about ALS versus BLS, or?
We will ask them to provide some additional information on that. While we wait, what do you consider your upper limit on UHU and why?
So for us, kind of that 0.5 is where we know we're working really hard. So that's call every hour essentially. So our goal for 911 is actually a 3429, but that's a budget number. So we actually know that we're typically not going to do that well with the increase in the number of responses. Typically, our 911 system runs at about a 3.7 to some days as high as a 0.42, depending on the number of resources, depending on, is it a 4th of July event, is it a New Year's Eve event, is there anything else special going on uptown? Civil unrest that we had here in the fall kind of put us in a different scenario, because we had units that were deployed in the areas that were having those difficulties. We have a SWAT medic team, so that took members off of the 911 side. So everybody's having to work a little bit harder. I wouldn't say that we work them too hard. I would say that they work very effectively, and we also do what we do a custom UHU for units, and we watch that very closely. So if a unit has been working really hard and we see that their personal UHU is getting a little higher or a little hotter, we actually try to get them to an outer line area and get them some downtime. Because we are a dynamic system, we have a little bit of ability to still do that.
Okay, and in follow-up to the previous question, we have, so you might have a patient that books non-emergent transport, but as a clinician arrives on scene, they realize that the patient actually requires a 911 response. Thinking subclinical sepsis, for instance, how do you manage the clinical risk if the call converts from non-emergent to 911?
So for us, they need to have a destination. So if they have an appointment and they're scheduling that appointment and they are at a residence, for example, if my mom needs to go to the doctor's office, she has a regular scheduled appointment. If we arrive on scene and find that the patient is potentially septic, then that doesn't change anything for us. An ALS unit is required to go to any residence. So the BLS units do not go to a residence. They do not respond on a 911 call, except as a BLS first responder, which is only on occasions of low system status level, or out of an MCI or something like that, where a patient has been completely checked by an ALS unit already, and we know that yes, this is indeed a 3 priority or a non-emergency transport. So for us, that ALS unit is always going to be on the scene with that patient to recognize that immediately, and we don't even have to call in another resource. That's not the important thing for us. The important thing is making sure that patient is taken care of. So then that patient just doesn't go to their doctor's appointment. They go straight to the emergency department. Yeah.
Okay, next question. Are any non-emergent transports considered mobile integrated health or community paramedicine with no transport, or is it just a low acuity transport?
They are all low acuity transports. We are currently looking at the community paramedicine piece. Carolinas Healthcare actually does some of that now, typically not in Mecklenburg County. I think it's because we're such a metro area. They actually do that in a couple of the surrounding counties that we have. But we have looked at that community paramedicine piece. We'll continue to look at it. Actually, one of our strategic objectives for the new year sounds a little strange, but it's to actually reduce unnecessary transport. So we want to know how we can work better with the community and do things a little bit differently to try and make sure that they're getting not just transported, but make sure they're getting to the right resource. Do they just need a doctor's appointment? Do they just need a blood sugar check, or do they just need a blood pressure check? Those are things that we're looking at for the future.
Okay. If your 911 and non-emergent ALS are separate, how do you determine who gets to work the 911 unit over non-emergent? Do you use a shift bid system?
We do use a shift bid system. We actually have the team of ALS net employees has probably a huge amount of tenure. They have relationships with patients that just astound me. We had one crew that actually took a patient home during a snowstorm here, which if you know anything about Charlotte, North Carolina, if my dog says it's going to snow, everything shuts down. But they actually shoveled the patient's driveway as well as the sidewalk leading up to their house in order to get the patient back in, and that's one of our regular patients. So they do have a lot of experience. They do have a lot of tenure. The BLS side is something that's a little bit new, and by new I mean probably the last 5 or 6 years. And because of that, the experience on that side is not quite as much. We do have a BLS team lead who is responsible for that truck. It's the same as a paramedic crew chief on an ALS unit. They're responsible for that unit. They're responsible for making sure that, hey, if I can't handle this patient, something's changed, then, hey, raise that hand and say, hey, I need an ALS unit. But the relationships that they have with their patients and the relationships that they have with the hospitals and the nursing homes, they recognize these people and they call them by name. And we go to they've been to a number of funerals. They've been to at a family side when something's happened, even when they're not on duty. So there's truly that relationship there that makes that a little bit different.
Have you made any requirements of facilities to have completed paperwork prior to arrival, and do you provide them with a packet or do they use their own forms?
Some of both, because it depends on where we are. So we actually have some contracts with the nursing homes, nursing facilities as well, that ensures that they have our appropriate paperwork, that they know what we need. They'll have a packet ready for us when we arrive. But if it's a scheduled transport, we actually have all of that information up front. So the net form that we use and that we provide them has that insurance information. It has date of birth. It has their contact, for family members. It has who's approving the transport and who's saying that this patient is stretcher transport only. If they don't meet those needs, if they don't meet the criteria for stretcher transport, then Medicare is not going to pay for it. So we make sure that we have all of that paperwork up front. It's the crew's responsibility to get that additional paperwork once they get on scene, and we do put that on that paramedic or on that crew chief of that unit. So if something's missing when they come back around, then it's that paramedic's responsibility to actually go back and get the additional paperwork or get that from them, as opposed to it being billing's responsibility. Yeah.
Two-part question. Is your staff full or part-time, and what scheduling program do you use?
We use ePro or eCore, which we had, well, I can't think of the name of the one that we used previously, but it's very good. It's very solid. We actually like it because there are things that we can tweak. You can put in multiple shifts and assign those to include, we have some crews that are just Wednesday, Thursday, Friday, 8 a.m. to whatever hours. They work a variety of 10, 12, 8-hour shifts. So that's how we do that. And I'm sorry, what was the first part of that question? That actually answered the second part.
The first part is your staff full or part-time?
We have some of both. We actually have upped our part-time staffing in recent years. We actually had a minimum initial or a maximum initially and had hit that maximum, and so we were actually turning people away from part-time. But we actually find a lot of value in the fact that people will, pick up shifts. eCore actually will allow us to only open up certain shifts. And so if there's a need that is more for a Saturday evening, we'll leave that open for a longer period of time in advance to try to fill it. And then once it's filled, we'll open up something else that, may not be quite as important, but we just kind of a nicety to have that covered. So, but our part-time staff is very valuable. We actually have part-time staff in communications center as well, who help out on the net side. We actually had one who just became a stay-at-home mom. Her daughter's having some developmental issues at home. So she is primarily a net telecommunicator, and so she comes in and works some additional hours and helps out part-time in that way, in that manner. But her focus primarily when she's here is the net side.
Is net a 24/7 operation or some other operational period?
It is 24/7. We take patients hospital to hospital or take patients home out of the emergency room at all hours of the day and night. Obviously, the biggest bulk of that is Monday through Friday, kind of that. We probably get started hot and heavy about 9 o'clock, and we go until around 1700. Some nights, some evenings, we're out as late as 8 o'clock trying to get patients home from the hospital and trying to get them, depending on what the volume has been for that day. But it is 24/7. And we staff accordingly as well. So our demand is there, so we staff the net units 24/7.
What are your utilization targets for the BLS units, the non-911?
For BLS, it's the same as ALS on the net side, and that's that 0.50. So it sounds pretty harsh, but we think that the net call piece, especially once they can have that schedule in advance, and once they know when they come in the morning, here's the possible schedule, and for BLS, that's probably going to stay pretty stable. We think that will enable them to have a much better grasp on, hey, this really isn't that bad, and hey, here's the point that I can grab a meal, or here's the point that I can call home and check on my family, those sorts of things. So the 0.5 is actually where they want to be because they want to be busy. They are the crews that want to stay busy and help out as much as they can.
How is your reimbursement for net calls to clinics?
For us, It really just depends on the clinic. If we see a large influx of patients that go to a particular location, we will attempt to get out to them and visit with them and let them know what we expect, let them know how to handle paperwork, and let them know that, here are the criteria. The patient if the patient can't get out of bed without help, if they can't walk, if they're not able to sit in a chair or wheelchair, then that stretcher is absolutely necessary. So we go out and we make sure that people understand the difference in, hey, I need a transport versus, hey, I need a stretcher transport. So we try to do that in advance. We have, had occasions where we've taken a patient or we've gone to pick up a patient and we arrive and the patient's walking across the room to get on our stretcher and we're like, whoa, hold up here. So we don't refuse, but we do very gently make sure that that patient knows, hey, your insurance or Medicare may not pay for this transport. We want to let you know what this cost is up front. We actually had a lady who walked away from us last week after we shared that with her over the phone. She actually hung up and found her own way home, just knowing that, oh, okay, maybe I'm not qualified for this, or maybe this is not the transport that I needed.
What is the biggest benefit you feel the software offers your organization? What did you use previously, and what made you change?
So we have TriTech CAD system. There really isn't a tool that we have that TriTech provides currently. The only difference that TriTech does in a 911 call and a scheduled call is a different call-taking screen. The difference in that call-taking screen is that it enables us to put in insurance information, date of birth, that sort of demographic information that allows our billing software to then pull that over and make that billing process a little bit easier. As far as dynamic deployment, as far as looking at demand, as far as moving units back and forth between the 911 and the net side, all of that currently is a manual process. So to make that and to take that net call tool and put that into play, we anticipate will be huge for our net controllers because it's going to make their lives so much easier. We'll still have to enter all of the information into CAD and make sure it's correct and follow up on that paperwork until that second phase is done, but that will enable that telecommunicator to focus on that patient and to focus on getting the right information and the right paperwork in, as opposed to worrying about, okay, who am I going to send on that call? Oh, they got popped for a 911 call. I can't use that unit. Now I've got to think through how to get to this next call on time. I've got this unit over here on the western side of the county, but my next net call or my next scheduled call is down on the south end of the county. How am I going to get them down there? That really doesn't make sense. They're spending a lot more time on the road if I do that. All of those pieces we anticipate that net call will help us do more effectively.
Are your facilities given an expectation of how much time in advance they can schedule?
So yes, but that expectation alone does not net us a huge value. We have 2 hospital systems. One is pretty good about scheduling in advance. One not so much all the time, at least not consistently. So we would like to improve that. We're not sure how to do that yet. We have worked with them on some processes. One of the things that we have set up in the next couple of weeks, we actually have their caseworkers who are coming over to observe in the comm center to understand how we function and how we make decisions. We'll have some that will, give us a day's notice and say, hey, this patient's leaving tomorrow. And we'll have some that call, an hour and a half, 30 minutes in advance and say, hey, this patient's got to go now. And they're just going home. They're just being dismissed. So we work closely with them to try to help impact that change or affect that change, but so far we've not found that magic bullet to help eliminate that completely or to get us the notice that we need for that.
How long did it take to set up the changeover to the new system?
So it's been a few months in the process. We're still in that implementation phase. We're blessed that we actually have a test environment to use for our CAD system, so we can put information into that test system to include building units, whether they're ALS or NET or BLS, and then play with that system move it back and forth, optimize, again, refresh, okay, we're going to take this unit off, oh, that call just got canceled, we're going to, move this call in instead. All of those pieces are pieces that we can use in a test system in order to practice and in order to affect the most change in advance of that move to production.
Regarding community health care, do you have follow-up programs such as ALS sees the patient, gives discharge meds? Will they follow up later? How do you manage this?
We do not currently. It's something that we've looked at, huge cost basis, as well as to the community. Probably the biggest two community programs that we have currently. We do what's called Omega through MPDS, through Medical Priority Dispatch, where if a patient meets certain criteria, they've had the flu for a week, and they just need somebody to work through them with how they need to be treated, we can actually transfer them to a nurse call line. The nurse can then give them instructions. Then if something changes in the call process, if suddenly they're having chest pain or they're having trouble breathing, then that nurse call center can actually transfer that call right back into our 911 system. So that is one. We've been doing that for probably, 5 years or so. The other, we actually have a high-frequency user program that we implemented. We have partnerships with Mecklenburg County and some of the resources that they have, DSS, that sort of thing. Both hospital systems have input. And if we have a patient that we see a high number of transports during a particular month, we can actually get in contact with that patient, have resources go out to that patient's residence, check on them. They then, every time that they call, that unit will actually take them to the same facility every time. So they're able to go to the very same facility or the very same emergency room. And that has seen huge results for us. We have cut those transports in some cases down completely, and in most cases, by far in half, if not better than that. So that has worked really, really well for us. We've only been doing that probably the last year or so.
What software are you using for patient care reports? Does TriTech talk to your patient care report software like ESO, each to transfer the initial call taking information such as the address and insurance information into the patient care report?
So we use Medusa or MedUSA for our Siren or for our EPCR piece. That information pulls directly from CAD, and actually a BCS product, our Marvelous product, is actually a conduit between those two systems. So because our units have mobile data terminals that are through Marvelous, that Marvelous piece has to be in between the two pieces. So as far as electronic patient care reports, those are then typed up by the crews, typically closed out, when they finish the call and when they check available at the hospital. They can actually go back in and add things or take things out, once they arrive at a post or something like that. Closeout is at the end of each shift for each of those tickets, and then we actually use TriTech, which is the same software as our CAD, for our billing software. So that suite billing is what that's called, and that is how that information gets from CAD to the patient care report and then to the billing piece. So all of that information is entered by the crews.
Okay. Well, we did have a question related to, can we download this webinar later? And there will be a link provided that will allow for the information to be downloaded. And with that, I believe that captures our questions from the audience. Okay. So thank you, Corinne, and to everyone who attended today's webcast. You will be sent a link to the recorded version of this event within the next 24 hours. And if you have additional questions that were not able to be answered, you may direct them to sales@bcs-gis.com, and that should be available at the bottom of the current slide. I would once again like to thank our sponsor, Bradshaw Consulting Services, for bringing this valuable information to us and our audience. and to our education partner, Ninth Brain, for hosting this webinar and for being our partner in this Pinnacle educational series, as well as our educational partner at Pinnacle and other Fitch and Associates educational programs. As a reminder, Corinne will also be speaking at Pinnacle in August, and you can find out more information on the conference at www.pinnacle-ems.com. Thank you all for attending today.